Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr. Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. My email is sreeklpm@gmail.com. I am also the medical author of the books Focused Neurology and Exam Oriented Clinical Neurology. We are continuing with the series of Prime Neurology. Prime Neurology, as the name suggests, contains the most important and basic neurology. It has a total of 50 episodes, 50 parts. So, if one listens to all these 50 episodes of Prime Neurology, I am sure the person would have acquired a good knowledge of neurology. We are right now on Prime Neurology Part 6. So we are on the 6th episode, Stroke, Part 3, Clinical Manifestations of Stroke. Clinical manifestations of stroke. First we'll talk about weakness. Unilateral weakness is the classical presentation of stroke. The weakness is sudden, progresses rapidly and follows a hemiplegic pattern. Upper motor neuron of the face, 7th nerve, is often present. 7th nerve is the nerve usually involved in stroke because all cranial nerves have bilateral innervation, but 7th nerve, the lower part, has only contralateral innervation. Because of that, stroke usually affects the 7th nerve and causes upper motor neuron weakness of the 7th nerve, which is often present. So here we see both the upper motor neuron and lower motor neuron. What is upper motor neuron? You can see the corticospinal tract, the leg area, the face and the hand area. They all come together, close together in the internal capsule, and then they start descending. They descend like this and cross at the level of the medulla oblongata and go to the opposite side to the spinal cord. So this entire tract is known as upper motor neuron and has basically got two components. One is the corticobulbar fibers going till the motor nucleus of the cranial nerves, and second is the corticospinal tract, which is going till the anterior horn cells of the spinal cord. So upper motor neurons has got two components, corticobulbar fibers and corticospinal fibers. Likewise, when it comes to the anterior horn cell, from the anterior horn cell it descends and goes as the motor root, plexus and the peripheral nerve, which is called as the lower motor neuron. So lower motor neuron also has two components, one coming from the anterior horn cell and coming as peripheral nerve, second from the motor part of the cranial nerve nuclei coming as the cranial nerves. So lower motor neuron also has two components, one the peripheral nerve coming from the anterior horn cell and second the cranial nerve coming from the motor part of the cranial nerve nuclei. So upper part has got two components, corticobulbar fibers and corticospinal fibers. Upper motor neuron has two components, corticobulbar fibers and corticospinal fibers. Likewise, lower motor neuron also has got two components, the peripheral nerve and the cranial nerve. So when there is a lesion here in the internal capsule, before it crosses over, there is a contralateral hemiplegia. When the lesion is in the spinal cord, when both the tracts have crossed, it causes tetraplegia, means all four limbs are involved. But when it comes below the cervical cord level and when the lesion is here, it causes paraplegia. That means only the lower limbs are involved. So this is about the upper motor neuron and the lower motor neuron. So now we have understood the differences between the upper motor neuron and the lower motor neuron. Now we'll go to the next slide. So what are all the differences between upper motor neuron lesion and the lower motor neuron lesion? Very important concept. In upper motor neuron lesion, when we inspect, there is no wasting. It is normal. Wasting may be there in some chronic conditions, but generally upper motor neuron lesion, the muscle mass is normal and there is no wasting. Whereas in lower motor neuron lesion, like anterior horn cell disease, like poliomyelitis or motor neuron disease, there is severe wasting. The muscle mass is completely wasted and there may be fasciculations. fasciculations, when the anterior horn cells get affected, there will be involuntary twitches of the muscle fibers, which is known as fasciculation. This is because of a law known as Cannon's law of denervation supersensitivity. When the anterior horn cells are denervated, they become supersensitivity to the chemical, and therefore they start contracting on their own, which is known as fasciculations. An involuntary contraction of the muscles or the muscle twitches known as fasciculation because of Cannon's law of denervation supersensitivity. Next, when we come to the tone, there is hypertonia in upper motor neuron lesions, otherwise known as spasticity. Whereas in lower motor neuron lesion, it is normal or decreased and there is no clonus. So here there is spasticity and clonus. So there is an increase in tone. The tone is also has got a specific pattern, spasticity. The tone is increased in flexors of the upper limb and the extensors of the lower limb. The tone is increased in flexors of the upper limb and the extensors of the lower limb, known as the anti-gravity muscles. Whereas here, the tone is normal or decreased. Pattern of weakness. It preferentially affects extensors of the arms and flexors of the legs, causing hemiparesis or paraparesis or tetraparesis. Preferentially affects the extensors in the arm. Here I need to spend some time to explain what are all the muscles which get preferentially affected in an upper motor neuron lesion. So it affects extensors in the arm. So what are the muscles which get affected in arms? Easy to remember by an acronym, DATES. D-A-T-E-S. D-A-T-E-S, DATES. D means deltoid, which is an abductor. A means abductor. T means triceps. E means extensors of the wrist, extensors of the fingers, and external rotators of the shoulder. S means supinator. So these muscles get affected. So when these muscles get affected, the opposite muscles, antagonistic muscles, will take over and results in the classic circumduction posture. What is that? When the deltoid gets affected, which is an abductor, they cannot abduct. So it will be flexed. D-A. T, when the triceps get affected, they cannot extend. So it gets flexed. E, extensors of the wrist, extensors of the finger, and external rotators of the shoulder are getting affected. So there will be internal rotation of the shoulder. When the extensors of the wrist and extensors of the finger get affected, they will have a flexion posture. And when the supinator gets affected, they will have pronation. The pronator will take over. So this is the classic posture of a hemiplegic person, circumduction gait. So in upper limbs, DATES, D-A-T-E-S are affected. Deltoid, abductor, triceps, extensors of the wrist, extensors of the fingers, external rotators of the shoulder, and supinator. So opposite muscles take over. So they'll have flexion because deltoid gets affected, triceps get affected. So again they have flexion, extensors of the wrist and extensors of the finger get affected. So again they'll have flexion, and supinator gets affected. They'll have pronation. When it comes to the lower limbs, flexors in the leg are affected. Easy to remember is HD for high density of the lower limbs. What is H? Hamstrings muscles and hip flexors. D means dorsiflexor. So when the hamstrings get affected, they cannot extend the knee. So the knee will be flexed. When the hip flexors get affected, again they cannot flex. It will be extended. When the dorsiflexors get affected, there will be plantar flexion. So it will be hitting the ground. So to clear the ground, they encircle and walk. To clear the ground, they encircle and walk, resulting in classic circumduction gait. So in lower limbs, HT, hip flexors, hamstrings and dorsiflexors get affected, resulting in characteristic circumduction gait. Whereas if we see the weakness in the lower motor neuron, it is typically focal in distribution of nerve root or peripheral nerve with associated sensory changes. Deep tendon reflexes. In upper motor neuron lesion, the reflexes are all brisk. Biceps, triceps, supinator, knee jerk and ankle jerk. Whereas in lower motor neuron lesions, they are decreased or absent. And the most important sign is the plantar response. In upper motor neuron lesion, there is an extensor plantar response, otherwise known as Babinski, where the big toe goes up and other toe goes for fanning. Whereas in lower motor neuron lesions, it is flexor. So these are all the very important differences between upper motor neuron lesion and lower motor neuron lesion. Now let's see the assessment of weakness. The clinical finding, the likely level of lesion and diagnosis. If only isolated muscles are affected, then it is radiculopathy or mononeuropathy. If both limbs on one side get affected, it is cerebral hemisphere. If only one limb gets affected, it is either neuronopathy, plexopathy. If both the lower limbs paraparesis, then it is spinal cord. Look for a sensory level. If there is fatigability, it is myasthenia gravis. That means morning they are all right, but as the time passes, as the day goes on, they become weaker and weaker, which is known as fatigability, very classic of myasthenia gravis. If it is bizarre, fluctuating, not following anatomical tracks, it is functional. So signs, if it is upper motor neuron, obviously it has to be corticobulbar fibers or corticospinal fibers, that means brain and spinal cord. If it is lower motor neuron lesion, that means it is peripheral nerve system. Evaluation of the weakness, very, very important. When we approach a person with stroke, evaluation of the weakness or the temporal profile of the illness, very, very important. If it is sudden and improving, it has to be stroke and mononeuropathy. Stroke patients present with sudden onset of weakness, and they can improve also when the edema reduces. So sudden and improving, always we need to think of stroke. Evolving over months or years, it is meningioma or cervical spondylotic myelopathy. Evolving over months or years is meningioma or cervical myelopathy. Gradually worsening over days or weeks, we have to think of cerebral mass or demyelination. Associated symptoms. Absence of sensory involvement. There is no absolutely sensory symptoms. We have to think of a pure motor system involvement, that is motor neuron disease or myopathy or myasthenia gravis. So this is very important in terms of assessment of weakness. Yeah, now weakness is over. Now we'll talk about speech disturbances. Cortical strokes, usually dominant or parietal lobe, can cause dysphasia with either difficulties in understanding speech, vernix aphasia, or difficulties in producing grammatically correct and fluent speech. We need to understand dominant cortex. What is dominant cortex? The cortex which has got language area is known as dominant cortex. For most of the right-handers, it is the left side which is dominant. That means the speech centers are situated on the left. For left-handers, more than 60% it is still on the left, but some may have it on the right. So right hemiplegic patients who are right-handed usually will develop aphasia when the left cortex gets affected. But when the right cortex gets affected and they have left hemiplegia, usually they don't have language disturbances because the language area is on the left and not on the right. Again, language areas, we have done a detailed episode previously, but suffices to say here is that we have basically vernix area and Broca's area. If vernix area gets affected, they cannot understand speech. If Broca's area gets affected, they cannot speak fluently. Visual defect. The third important clinical manifestation of stroke is visual deficit. Visual loss can occur as a result of lesions in any areas between the retina and the visual cortex. Visual symptoms affecting one eye only or due to lesions anterior to the optic chiasm. Amaurosis fugax. What is amaurosis fugax? Very important finding. Occlusion of the ophthalmic artery by thrombus leads to sudden blindness in one eye. If the blindness is transient, this is called transient monocular blindness or amaurosis fugax and is suggestive of internal carotid artery stroke. Stroke affecting the occiput lobe or optic tracts or radiations lead to contralateral hemianopia or small lesions, a partial field defect. So if we see the diagram, it will be better understood. So this is the diagram. The left eye, the right eye, these are the visual fields. The nasal fibers represent the temporal field. The nasal fibers represent the temporal field. Temporal fibers represent the nasal field. And the nasal fibers cross over to the opposite side. It goes to the lateral geniculate body, and from there it's the superior radiations, and then the lower fibers in temporal lobes, they go to the occiput lobe. So here you can see the retina, it comes as optic nerve, this is optic chiasm, this is optic tract, this is the lateral geniculate body, these are the lower fibers in the temporal lobe, these are the upper fibers in the parietal lobe, and finally occipital cortex. So this is known as optic radiation. By just looking at the clinical visual deficit, we can place the lesion. If there is a complete, these are the visual field defects. If there is a complete, if there is a lesion here, left optic nerve, there is a complete monocular blindness. Complete monocular blindness on the left side, whereas on the right side is normal. But if there is a lesion here at the level of the optic chiasma, only the crossing nasal fibers get affected. We all know that the nasal fibers represent temporal field. The nasal fibers represent temporal field, and therefore patient will present as bitemporal hemianopia. Very characteristic. Optic chiasm lesion presents as bilateral bitemporal hemianopia. One of the important causes of optic chiasm lesion producing bitemporal hemianopia is pituitary adenomas. The third lesion is here, that is in the optic tract. When the optic tract gets affected, the fibers here, the crossed nasal fiber and the same side uncrossed temporal fibers get affected. So this one and here this one. So they'll have homonymous hemianopia. That means same side there's a visual loss. So right homonymous hemianopia, you can see the same side there's a visual loss. Whereas in optic chiasm it is heteronymous. That means one side and here also the opposite side. So this is known as bitemporal hemianopia. Here it is known as homonymous hemianopia. This is known as heteronymous hemianopia. This is known as homonymous hemianopia. But when it comes to radiations, there will be quadrantonopia. If the lower fibers get affected, lower fibers represent upper field opposite, so they'll have right superior quadrantonopia. If the upper fibers get affected, upper fibers represent inferior field, so they'll have right inferior homonymous quadrantonopia. When it comes to the occipital lobe, they'll have again right homonymous hemianopia, but the central vision is spared, which is known as macular sparing. This could be explained by two concepts. One, the macula is in the occipital pole and therefore it is usually not affected, so there is macular sparing. Second, the macula is supplied not only by the PCA posterior artery but sometimes also by middle cerebral artery, so usually this is spared. So these are visual pathway and visual field defects by which we are able to make out the site of the lesion. And now we are talking about a visuospatial dysfunction. Damage to the non-dominant cortex often results in contralateral visuospatial dysfunction. Example, visual hemineglect. See, the right parietal lobe controls both the right and the left side, and the left parietal lobe controls only the right side. So the left parietal lobe gets affected, right visual field is affected, but this is compensated by the intact right parietal lobe which controls both the right and the left. And therefore left parietal lobe lesion usually do not produce right hemineglect. But when the right parietal lobe is affected, both the right and the left side is gone. The right visual field is compensated by the intact left parietal lobe, but there is no compensation on the opposite side, and therefore the right lesions, that is the non-dominant cortex, only produces hemineglect on the opposite side, visual hemineglect. So how do we test at the bedside? We'll ask them to draw a clock of 12 numbers. Usually they are equally spaced, but when we ask a person who's got non-dominant cortex involvement and visual hemineglect, he puts all the 12 numbers on one side, completely neglecting the left side. This is known as visuospatial dysfunction. So aphasia is very characteristic of dominant cortex involvement, and visuospatial dysfunction is characteristic of non-dominant involvement. The other important manifestations of clinical manifestation of stroke is ataxia. Stroke causing damage to the cerebellum or its connections can present as an acute ataxia, and there may be associated features such as diplopia and vertigo. Cerebellum is responsible for the fine coordination. It is the coordinator. So when the cerebellum gets affected, the fine coordination is gone, and therefore patients will have ataxia. They can have headache. Sudden severe headache is the cardinal symptom of subarachnoid hemorrhage, but may also occur in ICH if there is raised ICT. Headache also occurs in cerebral venous disease. Again, there is an important concept here. Brain by and large is insensitive to pain. We cut brain, there is no pain. It is only the meninges and the vessels in the meninges which are sensitive to pain, and therefore we get severe pain and headache only when the meninges get affected or vessels of the meninges getting affected. So when the meninges get affected, as in meningitis because of infection, or in subarachnoid hemorrhage because of the blood products irritating the meninges, or in migraine where the trigeminal complex gets affected, or in cerebral venous disease because of the sinuses getting affected, patient will have headache. Otherwise, brain is by and large insensitive to pain. Seizures. Seizures is unusual in acute stroke but may occur in cerebral venous disease and cerebral embolism. And coma. Coma is uncommon, although it may occur with the brainstem event or subarachnoid hemorrhage. To produce coma and loss of consciousness, the reticular activating system should get affected. So if only both the cortices get affected or brainstem get affected, person will have coma. If only one cortex gets affected, person will not have loss of consciousness because the RAS goes to both the cortices. So if one cortex gets affected, still they do not lose consciousness because the other cortex can compensate and patients will not have coma. So usually stroke patients do not have coma unless the brainstem gets affected where the ascending reticular activating system is close together or in subarachnoid hemorrhage. Now we shall come to the pathophysiology. Cerebral infarction. Cerebral infarction is most commonly caused by thromboembolic disease secondary to atherosclerosis in the major extracranial arteries, that is carotid artery and aortic arch. About 20% of infarctions are due to embolism from the heart. Another 20% of infarctions are due to diseases of small perforating vessels known as lenticulostriate arteries producing lacunar infarction, small sized infarctions. And another cause of pathophysiology for stroke is low flow strokes are occasionally seen with severe proximal stenosis and inadequate collaterals challenged by systemic hypotensive episodes. So when there is hypotension also they can develop stroke. So cerebral infarction is most commonly caused by thromboembolic disease secondary to atherosclerosis in the major extracranial arteries, that is carotid artery and aortic arch. 20% are because of embolism, 20% are because of lacunar infarctions, and the other causes being is the systemic hypotensive episodes. Stroke recovery. So lot of patients present with stroke, how many of them recover? So what are the factors which help in the stroke recovery? Variability in stroke recovery is influenced, most important is by collateral vessels. If there are good collateral vessels, obviously they are going to increase because the collaterals come and supply the part which is affected by ischemia. Blood pressure and the specific site and mechanism of vessel occlusion. So variability in stroke recovery is influenced by, most important is collateral vessels, blood pressure, the specific site and the mechanism of vessel occlusion. TIA, transient ischemic attack. If blood is restored prior to the significant cell death, the patient may experience only transient symptoms. Amaurosis fugax, transient monoocular blindness, is a particular form of TIA due to retinal ischemia. Patients describe a shade descending over the visual field and the ipsilateral carotid artery is often implicated. So what are the risk factors for stroke? The risk factors of stroke can be divided into two categories. One is the fixed risk factors. Second, fixed risk factors are the age, sex, male more than female, previous vascular event like myocardial infarction, stroke and peripheral vascular disease, genetic mutations like cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy and sickle disease. The modifiable risk factors, it could be blood pressure, cigarette smoking, and I would like to emphasize on blood pressure. The blood pressure or the hypertension is the single most important modifiable risk factor for stroke. I repeat, hypertension is the single most important modifiable risk factor for stroke. For myocardial infarction, it is dyslipidemia. So risk factors always we have to consider blood pressure, cigarette smoking, high density HDL cholesterol, diabetes mellitus and atrial fibrillation. High low density lipoprotein cholesterol. High density HDL cholesterol is protective, whereas LDL cholesterol is a risk factor. So when there is a high low density lipoprotein cholesterol, it's a risk factor. Then we have chronic kidney disease, excessive alcohol intake, estrogen containing drugs like oral contraceptive pill, hormone replacement therapy, polycythemia, drugs like cocaine, heart disease, congestive heart failure and infective endocarditis. Ischemia modifying factors. So what are the factors which modify ischemia? After the occlusion of a cerebral artery, the supply of oxygen, glucose and other nutrients to tissue falls and neuronal function begins to fail. After the occlusion of a cerebral artery, the supply of oxygen, glucose and other nutrients to tissues falls and neuronal functions begins to fail. Here comes the collateral vessels. Collateral vessels, after the occlusion of a cerebral artery, infarction may be forestalled by the opening of the anastomotic channels from the other arterial territories that restore perfusion to its territory. So very important is collateral vessels. Similar reduction in perfusion pressure leads to compensatory homeostatic changes to maintain tissue oxygenation. These compensatory changes can sometimes prevent occlusion of even a carotid artery from having any clinically apparent event. So what are they? So here you see the homeostatic responses. So these are the symptoms and here it is infarction. So we are talking about various homeostatic responses: the perfusion pressure, the cerebral blood volume, the blood flow, the cerebral oxygen extraction and cerebral oxygen metabolism. So these are the homeostatic responses to falling perfusion pressure in the brain following arterial occlusion. Vasodilatation initially maintains cerebral blood flow. So you can see here, so when there is ischemia, there will be vasodilatation which tries to initially maintain the perfusion pressure, but after which it also cannot maintain the perfusion pressure. So vasodilatation maintains the cerebral blood flow, but after maximal dilation there is a further fall. Then there will be cerebral oxygen extraction that also starts increasing, but after some time it also falls. Cerebral oxygen metabolism tries to be, it tries to maintain, but after that it also starts falling. So these are the homeostatic responses. Thresholds for cerebral ischemia. This is the cerebral blood flow, ml per 100 grams per minute, 50, 40, 30, 20, 10, 0. So when there is a fall, initially there is an increased oxygen extraction, but below 20 ml per 100 grams per minute, the failure of electrical function starts, so symptoms starts appearing, and below about 10 ml per 100 grams per minute, there is failure of ion pumps, potassium efflux, sodium influx, and there is cell death. So the thresholds of cerebral ischemia. Symptoms of cerebral ischemia appear when the blood flow has fallen to less than half of the normal and energy supply is insufficient to sustain neuronal electrical function. Full recovery occurs if this level of flow is returned to a normal, but not if it is sustained. Further blood flow reduction below the next threshold causes failure of the ionic pumps and starts the ischemic cascade, leading to cell death. So now we shall see what is the ischemic cascade. So when the blood supply becomes insufficient, there is a cascade. There's a chain of events going on when there is ischemia, known as ischemic cascade. So the process of ischemia and infarction. First, you can see here the oxygen is reduced. There's an anaerobic metabolism. So first is the reduction of blood flow reduces supply of oxygen and hence adenosine triphosphate ATH. Hydrogen is produced by anaerobic metabolism of available glucose here. The second point, here is the second point. So energy dependent membrane ionic pumps fail, leading to cytotoxic edema, membrane depolarization, allowing calcium to enter, releasing glutamate. The third point is that the calcium, you can see the calcium here, the entry of calcium. Calcium enters cells via glutamate gated channels. And fourth, this is the fourth one. So what happens? It activates destructive intracellular enzymes, lipid peroxidases, proteases, nitrogen oxygen synthetase. And what happens? The next point is that it destroys intracellular organelles and cell membranes with release of free radicals. You can see the free radicals here. Free fatty acids, thromboxane and prostaglandins. So destroying intracellular organelles and cell membranes with release of free radicals. Free fatty acid release activates procoagulant pathways that exacerbate, now they start exacerbating the local ischemia. Then finally the sixth point is that glial cells take up hydrogen ions. You can see here, they take up hydrogen ions, can no longer take up extracellular glutamate and also suffer cell death, leading to liquefative necrosis of whole arterial territory. So this is the ischemic cascade, the chain of events following ischemia. Ischemic penumbra. Now we need to know another concept, ischemic penumbra. Radiologically, a cerebral infarct can be seen as a lesion that comprises a mixture of dead tissue that is already undergoing autolysis and a tissue that is ischemic and swollen but recoverable. It can be recoverable. That is known as ischemic penumbra. So first is the core infarction where it is irreversible. Second is the swollen area, ischemic penumbra, where it is recoverable. And third zone is the normal area. So this is ischemic penumbra where it is ischemic, where there is ischemia, but it is still in the reversible state. That is ischemic penumbra. So thrombolysis, we target this ischemic penumbra. Yeah, once there is ischemia, what happens? There is cytotoxic edema, usually in the 2nd to 5th day. So the infarct swells with time and is it at its maximal size a couple of days after stroke onset due to cytotoxic edema. The 2nd day it becomes maximum. At this stage it may be big enough to exert mass effect both clinically and radiologically. So sometimes we need to do decompressive craniectomy so that the edema can be taken off. The patient survives the acute stages of infarction. Healing begins with inflammation to clear dying tissue, recovery of some neurons and reorganization of some cerebral function to other brain areas. Yeah, so far we've been talking about ischemic stroke. Now we shall talk about the intracerebral hemorrhage. The commonest cause of intracerebral hemorrhage is a rupture of small blood vessels due to hypertension. Explosive entry of blood into the brain parenchyma causes immediate cessation of function in that area as neurons are disrupted and white matter fiber tracts are split apart. Vomiting and drowsiness occur in some cases with intracranial pressure and headache is common. Signs and symptoms are often not confined to a single vascular territory. Whereas infarction, it is confined to a single vascular territory, but signs and symptoms are often not confined to a single vascular territory. There will be a lot of edema. Etiology are diverse, but hypertension is the most common cause. But what are the other causes of intracranial hemorrhage? Head trauma. Head injury is very important. Coup and contra-coup injury due to brain deceleration. The characteristic location of the frontal lobes, anterior temporal lobes, subarachnoid and extraaxial, subdural and epidural. Hypertensive hemorrhage. I want to make an important comment here. The hypertensive hemorrhage, there are common sites: putamen, pons, thalamus and cerebellum. So if we see hemorrhage in putamen, pons, thalamus, cerebellum, it is hypertensive hemorrhage. Chronic hypertension produces hemorrhage from small vessels, 30 to 100 micrometer vessels in these regions. And another important cause is transformation of prior ischemic infarction. Basal ganglia, subcortical regions, lobar. It occurs in 1 to 6% of ischemic strokes with predilection for large hemispheric infarctions. So when there is a large hemispheric infarction, there is a chance of transformation of prior ischemic infarction. Metastatic brain tumor, lobar. Usual causes are lung, choriocarcinoma, melanoma, renal cell carcinoma, thyroid and atrial myxoma. Coagulopathy, it can occur in any place. The risk for ongoing hematoma expansion. So another important point of coagulopathy is that it does not produce a sudden weakness like hypertensive hemorrhage. Coagulopathy, because of deficiency of clotting factors, it takes time. So the symptoms will be occurring slowly and producing in a in a gradual manner. It does not occur suddenly as that of hypertensive bleed. And that the characteristic meniscus sign when we take CT. So drugs, any lobar or subarachnoid, usually cocaine and amphetamine causes arteriovenous malformation. It will be lobar, intraventricular or subarachnoid. Risk is 2 to 3% per year for bleeding if previously unruptured. Arteriovenous malformation means there is a direct communication between the artery and the vein. So there is no intervening arteriolar, capillary and venule. So it is easy for it to rupture and cause hemorrhage. Aneurysm, likewise dilatation of the artery can rupture and cause hemorrhage. Subarachnoid, intraparenchymal, rarely subdural, mycotic and non-mycotic forms of aneurysm. Amyloid angiopathy, usually seen in elderly, where there is a deposition of amyloid in the vessels, usually seen in elderly, and it is lobar. So degenerative disease of the intracranial vessels associated with dementia, rare in patients with less than 60 years. Again, there could be cavernous angioma, where it could be intraparenchymal, multiple cavernous angiomas, dural arteriovenous fistulas, it will be lobar subarachnoid, produces bleeding by venous hypertension, capillary telangiectasis, usually brainstem, rare cause of hemorrhage. Hypertensive hemorrhage, as I said, these are the common locations. Hypertensive hemorrhage typically occurs in the following locations. Putamen, when it occurs in putamen, there is a contralateral hemiparesis, often with homonymous hemianopia. Thalamus, there is hemiparesis with primary sensory deficit because all the sensory tracts goes to the thalamus. Pons, there is quadriplegia. There are pinpoint pupils. Both the pupils are constricted. Why? Pons is supplied by single basilar artery. So when it ruptures, the blood goes bilateral and affects both the sympathetic tracts, and both pupils get affected because both sympathetic tracts getting affected. So they will produce pinpoint pupils. And we know that the horizontal eye movements are in the pons and vertical eye movements are in the midbrain. So when the pons gets affected, there will be impaired horizontal eye movements. If the cerebellum gets affected, there will headache, vomiting and gait ataxia. Note, a neurological deficit that evolves gradually over 30 to 90 minutes strongly suggests intracerebral bleed. Raised intracranial pressure. If the hematoma is big enough, it acts like a mass lesion, causing shift of intracranial content due to raised intracranial pressure, producing herniation and sometimes death. If the patient survives, the hematoma is gradually absorbed, leaving a hemosiderin line slit in the brain parenchyma. So these are all the important concepts of the clinical manifestations of stroke. The other important concepts of clinical neurology I have put in a book called Exam Oriented Clinical Neurology, written by me, Dr. Sreenivas, published by White Army Publication. This book will be useful for students appearing for clinical neurology exams. So if interested, this book could be purchased. The other book I have written is Focused Neurology, written by me, Dr. Sreenivas, published by CBS Publishers and Distributors. It contains all the essential points of theoretical neurology. So this book will be very useful for students appearing for Viva or oral exams. This book is available online from all leading booksellers including Amazon. So if interested, this book could be purchased online. I hope you have enjoyed listening to these wonderful concepts of clinical manifestations of stroke. If you have enjoyed, please like, subscribe and share this YouTube link. But again, I would like to reiterate the fact that there are 50 episodes of Prime Neurology. We have just completed another episode of Neurology. If one listens to all these 50 episodes of Neurology, I am sure one would have acquired a good knowledge of neurology. So I suggest everyone to listen to all these 50 episodes of Prime Neurology. So if you have liked, please share the link, like and subscribe my YouTube channel, Dr. Sreenivas Medical Concepts, which is India's leading neurology educational YouTube channel, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.